What's up, everyone? Welcome to Chalk Talk Med, where I cover high-yield topics for medical students. In this video, we're going to learn about choledocholithiasis, an important complication of gallstones. So let's first talk a little bit about the gallbladder and the biliary tract. So the gallbladder is an important organ that sits right here in the gallbladder fossa, which is in the inferior portion of the liver in the right upper quadrant of the abdomen, and its main job is to store and concentrate bile. You may remember that bile is this green fluid that's made by the liver. It's secreted through the common hepatic duct. Some of it goes straight into the intestines this way, and the rest of it goes up the cystic duct into the gallbladder to be stored. And then once we eat, there's release of the hormone cholecystokinin, which is going to cause the gallbladder to contract and release this bile through the cystic duct and the common bile duct into the small intestines, where the bile acids are going to emulsify fat and help with absorption of our dietary lipids. The main clinical consequence associated with gallstones is with gallbladder is gallstones, and these can either be cholesterol or pigmented. The problem isn't having gallstones themselves. The problem is that these gallstones can lodge and obstruct flow proximal to them, which is going to lead to their clinical symptoms. All right, so now let's talk about the symptoms of the complications of gallstones. Many people with gallstones are asymptomatic. So in these patients, this is an incidental finding. They get an abdominal imaging as part of workup for something else, and they're incidentally discovered to have gallstones, but they have no symptoms. So the point is, just having gallstones by itself doesn't mean that you have symptoms, but it does put you at higher risk for some of these complications. On the other hand, many patients with gallstones will experience one of these complications that are listed here. In another video titled Gallstone Complications, I actually have a comparison of all 6 of these, but in this video today, we're going to focus specifically on this one, choledocholithiasis. So chole means bile. Doco refers to ducto, which refers to the duct, and in this case, specifically the common bile duct. And anything that ends with lithiasis in medicine has to do with stone formation. So you put it all together and you have choledocholithiasis, means when you have a gallstone that's in the common bile duct, and that's the condition we're talking about today. And I want to be very clear that this is different than cholelithiasis. So here there's no doco, so this is specifically just talking about a gallstone. So this only means the patient has a gallstone typically found in the gallbladder. But what we're talking about in this video is choledocholithiasis, which is gallstone in the common bile duct. All right, so let's talk about these gallstones in the common bile duct. How do they end up there? So there's 2 ways. Most commonly, they migrate down from the gallbladder like this. They go down the cystic duct into the common bile duct where they get stuck. Less commonly, they can also form directly in the common bile duct, but again, more common, they come from the gallbladder. So now let's talk about the key clinical findings of choledocholithiasis, because this is what's really high yield for your exams and for you to know clinically. So there are 4 important findings that I've listed here, and all of these have to do with common bile duct obstruction, which is the underlying pathophysiology. So if you keep this in mind, it'll be very easy to remember this. Number 1, persistent right upper quadrant pain. So right upper quadrant because that's where the biliary tract is, and persistent because you have a fixed obstruction here in the common bile duct. The stone is lodged here and it ain't moving. And this is different than biliary colic, where you had a transient obstruction of the gallbladder neck, which caused transient pain that resolved. Here, pain doesn't resolve. Also, this should be associated with nausea and vomiting. Anytime you have irritation of the biliary tract, in addition to pain, you can get nausea and vomiting. Numbers 2 and 3 have to do with bilirubin. So here you have an obstruction of the flow of bile. So since bile can't be secreted into the intestines, it's going to back up. So you're going to have high blood levels of bilirubin, which is clinically going to manifest as jaundice. And since this jaundice is due to obstruction of the common bile duct, this is known as obstructive jaundice. And it's important to remember that whenever you have obstructive jaundice, the type of bilirubin that's elevated is direct or conjugated bilirubin. Number 3 is also related because you don't have bilirubin in the intestines now because it's being blocked from entering. Therefore, the stools are going to be pale because bilirubin in the intestines is what ends up turning into stereochobilin, which gives the feces its brown color. So since it is absent, the outcome is going to be pale stools. And since the bilirubin levels are now accumulating in the blood, eventually they're going to get filtered by the kidneys, which is going to give the urine a dark orange color. So pale stools and dark urine is a classic finding associated with obstructive jaundice. And the final set of lab findings are elevated alkaline phosphatase and GGT. So these are both important enzymes that are found inside of cells that line the common bile duct. So when there's an obstruction there, these levels are going to increase in the blood, and so they're used as serum markers for common bile duct obstruction. So since that's what we have here, the levels are going to be elevated here, and these are the key findings associated with choledocholithiasis. Important to recognize that there's no itis here, so there's no inflammation, so you should not be expecting fever or leukocytosis here, and this is how you would distinguish this from cholangitis. Now, to confirm the diagnosis that you have a stone in the common bile duct that's causing an obstruction, you need to visualize it. So you can do that with an ultrasound. An ultrasound is pretty good. It's our go-to for anything related to the biliary tract. And so it can usually pick up that there's a dilated common bile duct, but sometimes it's not as good as actually visualizing the stone in the common bile duct as it is in visualizing the stones in the gallbladder. Therefore, since they may not see the stone on the ultrasound, if that's the case, then we would use another test, which is either MRCP or ERCP, to be able to actually visualize the stones themselves in the common bile duct. All right, so both of these tests, MRCP and ERCP, obviously end with CP, which stands for cholangiopancreatography. That means that they both evaluate the biliary tract and the pancreas. The difference between them is the way they do this. So in MRCP, their evaluation is done by an MRI scan, that's why it's MR, whereas in ERCP, the evaluation is done by an endoscopy procedure. So now let's talk about each, starting with MRCP. All right, so here's an MRCP of a patient with choledocholithiasis. It's actually a really nice review of the anatomy as well. You can just compare it with the cartoon diagram here. So let's go through these labels. So A, this is obviously the gallbladder, and inside of it, if you look, you can actually see these tiny little dark spots. These are filling defects, and so these are gallstones within the gallbladder. And as you know, the gallbladder empties out through the cystic duct, and the cystic duct joins the common hepatic duct right here to form the common bile duct. So if you take a look at B again, the arrow is pointing at a bunch of small little filling defects again. Once again, these are gallstones, but here these are gallstones within the common bile duct. So this is your choledocholithiasis right here, gallstones within the common bile duct. Now for completeness, we can see choice C and D as well. So C is a duct that's coming off to the side to connect to the distal part of the common bile duct. So of course this is the pancreatic duct, and D is the final destination, which is duodenum with some fluid inside of it. Now the key here is that this test, because it's an MRI imaging study, it is diagnostic only, meaning that it can only identify the stones. It can't directly treat or remove them, which is going to be in contrast to ERCP that I'm going to explain next. So ERCP, on the other hand, is an endoscopic procedure. GI will insert a camera into the patient's mouth, go down the esophagus, into the stomach, and into the small intestines and the duodenum, where this camera has a special side viewing camera that actually can look inside the ampulla of water into the biliary and pancreatic ducts. And once it goes in there, it can actually inject contrast and take some fluoroscopy images and be able to identify obstruction and stones. The one big benefit of ERCP over MRCP is that it is not only diagnostic, but it is also therapeutic, because not only can you visualize it, but you can actually use this little grabber device to take the stones out of there and remove them. And that's what you're seeing here, a couple of pigmented stones in the duodenum that have been pulled out of the common bile duct. Now, so that's the benefit, but the downside is that it can be associated with complications. There are two major complications of ERCP to be aware of. One is pancreatitis, and the other one is acute cholangitis, which is inflammation of the biliary tract. And both of these happen because as part of the procedure, you're irritating the ducts that are near the pancreas and the biliary tree, and you can potentially cause inflammation in these areas. All right, now we can finish up our discussion by talking about the complications and treatment of choledocholithiasis. So let's start with complications, and there are three main ones. Number one, liver injury caused by obstruction of the biliary tract. This is going to lead to backup of bile, and you can see elevated transaminases, ALT, and AST. Number two, pancreatitis. So a distal common bile duct stone can also obstruct the pancreatic duct, leading to inflammation of the pancreas, aka pancreatitis. Number three, acute cholangitis. So anytime you have obstruction of flow, for example, obstruction of bile flow, this can set up a perfect environment for bacterial growth and infection. So this can lead to bacterial infection of the biliary tree. Now talk about treatment of choledocholithiasis. So the problem is you have a gallstone that's obstructing the common bile duct. So the treatment is to remove the gallstones that are obstructing the common bile duct. And you can do this either by ERCP, which is what we already talked about. The other option is to do a surgical removal of the gallbladder with common bile duct exploration. And this could also help you perform the removal of the gallstones from the common bile duct. Okay, that is it, and that is all. I hope you learned a lot. If you enjoyed this video and want to learn more about this topic, please check out these related videos that I've linked here. You can also search this channel, Chalk Talk Med, for other topics to see if they're covered. And if there are any other videos that you would like to see, or if you just want to give some feedback, please feel free to drop your thoughts in the comment section. Thank you for watching, and I'll see you next time.